And we are logging on maybe 30 seconds early because we know that there are over 400 people that have registered for this event as part of Lympha Press Lipedema Awareness Month. We welcome you, and we're so glad that you have joined us for what is always our premier event of every June, which is when Dr. Karen Herbst presents for us. Dr. Karen Herbst is the preeminent name in lipedema research. She is a beacon of hope to lipedema patients. She is also the Chief Medical Officer for Lympha Press. And that collaboration is really part of our commitment to the lipedema patient population and to help encourage, support, and really be behind any advances to help this patient population. I am Brenda Viola. I'm happy to be your host today. If you are with us, please let us know who's here in chat, where you're from, how excited you are to hear Dr. Herbst speak today. I have been fielding calls and emails from all over the world in the last week. People saying, will this be recorded? Can I get the replay? A lot of people, especially in Europe, this isn't the optimal timing for them. So they definitely want to see the replay. But you know what? We know we're going to hear such amazing information. You're going to watch it over and over and over again. And if you saw or heard Dr. Herbst present at FDRS earlier this year, this is not the same presentation. She's actually built on it. There is new information, and the title is A New Theory. Lipedema is caused by subclinical compartment syndrome. I cannot wait to sit back and listen to you, Dr. Herbst. We are honored to have you with us today. Please take it away.
Thank you so much, Brenda, and thank you for Lympha Press for sponsoring this event. And your outreach is obvious with over 400 people attending or wanting to listen to this event. So I am talking about a new theory today. I did present it at the Fat Disorders Resource Society conference in April. I did change it up a little bit because I couldn't help myself. But I do want to say this presentation is for Lipedema Awareness Month, and my goal would be to prevent lipedema from developing in our children, which is why I have this little girl with this cute little pink hat on. So my disclosure is I am the medical director of Lympha Press, and I did join Lympha Press because they are so open to working with patients with lipedema and because they are interested in supporting research on lipedema. So I just want to thank from the bottom of my heart, Lympha Press, for all you do. And I can't go any further without talking about this man, Dr. Jose Luis Simarro. He is a very close friend of mine from Madrid, Spain. And he is a physician. He was a family practice doctor, but that wasn't enough for him. So he went back and he got degreed in cosmetic medicine and surgery, anti-aging medicine and nutrition. He dedicated his practice to trying to reduce fat on the body using non-surgical techniques. And he opened the Lipedema Institute in Madrid, Spain, but he also works in Barcelona, and he wants to better diagnose lipedema, and he really wants to cure it. And he really is a visionary. And I really, this presentation would not be possible without him. So some take-home concepts that I want you to have, and as you go through this, you can think about these as they come up, and that is compartment syndrome may play a role in lipedema pathophysiology, that the deep and superficial veins in the leg are connected by direct and indirect perforator veins. So there's a web of connection between the deep and superficial venous system, but the same is not true for the lymphatic system. So there are minimal to no connections between the superficial lymphatic system and the deep lymphatic system in the leg. And also, finally, the calf muscle pump is important in lipedema pathophysiology. So I probably do not have to tell you what lipedema is. So in a nutshell and really quickly, lipedema affects primarily women. The subcutaneous adipose tissue, or SAT, is nodular. The arms and legs are affected, and we also think that the abdomen or the torso can be affected as well. And the feet and hands are unaffected, and that will be important to talk about near the end. It's often painful and tender. It feels heavy. Easy bruising is common, and there is edema in the tissue. So why? So there are 4 concepts that we know are prominent in lipedema and well supported. One is that the immune system is activated. And there's one study showing elevated levels of platelet factor 4 in the blood. Not the best study in the whole world because they compared the blood of women with lipedema to primarily men, but definitely intriguing, needs to be repeated. There are increased macrophages in tissue, that's clear. There are inflammatory cytokines in the tissue and the blood. And there's an inflammatory angiogenesis in the skin and tissue, meaning that blood vessels are growing in the tissue in response to inflammation, and they are growing a little bit differently. These blood vessels also are inflamed, so there's a microangiopathy, and they leak. So there's more vascular permeability. So they're actually adding more fluid to that interstitial space. Number 2, lipedema tissue is unhealthy. It expands by hyperplasia and hypertrophy. So you get more new baby adipocytes, but also the adipocytes that are there grow in size. And these are hypertrophic adipocytes, and they're strongly related to insulin resistance and other aspects of metabolic syndrome. So lipedema tissue appears to be metabolically unhealthy, despite its location, which is in the gynoid area, hips, thighs, and buttocks. And we know that fat generally in this area does not correlate with diabetes. And sure enough, we do not see a lot of diabetes in the population. But then why is lipedema tissue unhealthy? So this is something that we need to figure out further. Number 3, women with lipedema have venous disease. So in 25 to 50% of women, there's something wrong with the venous system. Either there's chronic venous insufficiency, varicose veins, or there are a lot of spider veins or reticular veins or telangiectatic veins. And what I've noticed in my time as an endocrinologist is that I'm not a vein doctor by any means. I have a lot of friends who are vein doctors, but it seems like a lot of the vein disease that's being described as large vein disease. So in your primarily superficial veins, your greater saphenous vein, your small saphenous vein, and then also in deep veins, but the smaller veins are not well studied. And I think what one gift that lipedema tissue can give to the field is that we need to study these small veins and not just the larger veins. And number 4, there is no obstruction of the lymphatic system in women with lipedema. So this is not a primary lymphedema where there's malformation of the lymphatic system. And this has been shown by nuclear medicine lymphoscintigraphy, by indocyanine green imaging. However, the lymphatic vessels can be dilated, especially in the calves. They can be leaky, and they can be sluggish. So there's something not right with the lymphatic system, but it is not obstructed. So lipedema is inflamed, metabolically unhealthy subcutaneous adipose tissue or fat, and there are leaky, damaged capillaries, veins, and lymphatic vessels. So both of these conditions cause fat to grow. So let's dig into the compartments of the leg. And this is something that I don't remember well from medical school. I think if you are a surgeon, you probably better understand compartments. And I would hope that in physical therapy and occupational therapy, and even in massage therapy, that you understand that there are compartments in the legs and the arms. So what is a compartment? It is a grouping of muscles, nerves, blood vessels, lymphatic vessels, and adipose tissue in the arms and legs. And over to the figure on the right, you can see an example of those compartments. And what makes them a compartment is that surrounding those contents is a tough membrane called fascia. And fascia, by definition, which it is actually not very well defined in the literature, and there's a lot of contention on what it is exactly, but it's connective tissues working together. So there's different types of connective tissue that make up fascia. And the role of fascia is to keep the tissues in place. And so the fascia doesn't stretch or expand very easily. So you would think that something that would cause the tissue to stretch or expand easily might be a problem. So what is compartment syndrome? It's increased pressure within a compartment. And this is not just a small increase in pressure. This is a pathologic increase in pressure within that compartment. And there are different types. So there's acute compartment syndrome. And if you start reading about it in the literature, this is what you're going to read about usually first, because it's a medical emergency. It's when tissue pressure rapidly exceeds the venous pressure and impairs the blood outflow. So you get a lack of oxygenated blood in that compartment. Waste products begin to build up because there's no outflow. There's a decrease in peripheral sensation because nerves are irritated and muscle and nerves actually undergo necrosis. And so again, this is a medical emergency. And it can happen, for example, with a rapid bleed into a compartment, for example, a muscle compartment, causing that muscle to undergo necrosis. And this can happen, for example, in vascular Ehlers-Danlos, or if there's a trauma causing a severe bruise, and often acute compartment syndrome happens after a fracture. It can also happen when you compress a limb for too long and suddenly somebody develops acute compartment syndrome. For example, they have a cast in place or a blood clot or surgery that blocks a vessel. And then there's chronic compartment syndrome. And I think this better defines lipedema. So the definition of chronic compartment syndrome is increased tissue pressure within a fascial compartment due to any increase in volume within its contents. So that could be an increase in volume of a vein. It could be increase in volume of adipose tissue. It could be increase in size of a muscle, or it could be a decrease in size of the fascial covering or its distensibility. So if the fascia covering became very fibrotic, which we know happens in lipedema tissue, or the size decreased over time, and we know that fascia can contract. So if it's continuously contracting for one reason or another, that would be another cause of chronic compartment syndrome. And what distinguishes it from acute compartment syndrome is that there's an absence of a traumatic event. So as I mentioned, there can be overexercise causing a swollen, enlarged muscle. The fascia can become thick and fibrotic. For example, if you have hypermobile joints and your fascia is getting all these nicks and dings or micro tears causing inflammation, that can cause fibrosis and cause that fascial compartment to shrink. You can get it by venous hypertension. I have not seen that reported. Obviously, I have some more work to do to dig into the literature, but I'm sure my phlebology and vascular surgeon friends know about this. So what about lipedema fat overgrowth? Could that cause compartment syndrome? And that's what we're here to find out. So let's start by looking at fat and female fat versus male fat. So if you look at female fat on the left, what you see there are larger adipocytes. Women have more fat than men. You can see that in this man, he has more muscle than the woman. But look at the fascia in between the fat lobules, which are the dark circles. You can see that they're very thin. In fact, it looks almost transparent, whereas the fascia or septae in the male fat are thick. So could it be that just women are genetically programmed to have different connective tissue than men, or that our hormones create a different type of connective tissue or a weaker connective tissue? And in fact, when they actually tested whether the adipose tissue connective tissue was weaker in females, it was. So men's fat is just generally stronger. So if we have a weaker tissue, could it be that if we have adipose tissue expansion, that female tissue would allow the fat to grow, whereas male tissue would not? And that could in and of itself contribute to compartment syndrome. We also know that almost 60% of women with lipedema have hypermobile joints. And that's in at least 2 of my studies. And there's another study that should be coming out this year by Dr. Wright's group that showed a similar number. So could hypermobile joints in combination with female chromosomes, genes, and female hormones all contribute to the increased development of fat and lipedema? And could that fat grow within the different compartments? So that's what I'm asking on this slide. Does weaker adipose connective tissue in women lead to lipedema? And you can see that there's increased fat tissue on the arm. It's on the posterior aspect of the arm. And in the arm, we have the posterior compartment and the anterior compartment. So what is it about these compartments that is causing fat to grow? Well, here's another view of the arm and another view of where lipedema tissue is growing on the posterior aspect of the arm. So could it be something within these muscle compartments that is inducing fat to grow? Or could it be something around the blood vessels, these leaky lipedema blood vessels in the arms that's causing the fat to grow? So we're back to what I said before. We've got inflamed adipose tissue and we have leaky blood vessels. And when I was at the University of Arizona, we showed that by looking at the skin of women with lipedema versus controls, that there were more leaky vessels in the skin and lipedema compared to the controls. And you can actually look at the paper and see what criteria we used for that. And we based it on leaky lymphedema vessels. And then there's also a group out of Vienna showing that if they take lipedema tissue and grow it up in a petri dish, if they take the fluid that's secreted by that lipedema fat tissue and put it onto healthy endothelial cells or healthy blood vessels, those blood vessels seem to leak. So we've got inflammation and leaky vessels. So perhaps in those compartments that it is the vessels that are causing lipedema and that it's inflammation that starts it. So if more fluid enters that interstitial space from the blood vessel, so here we have two fat cells, we have our connective tissue fibers, we have our proteoglycans that bind up fluid, or we have free fluid. We know that tissue doesn't like free fluid. So if more fluid is entering, then we should see that more fluid is also leaving through lymphatic vessels. And in fact, John Rasmussen's group actually showed that. So they looked at lymphatic vessel pumping in early lipedema, meaning stage 1 and stage 2. And they also looked at a few women with stage 3 lipedema. And what they found was that the lymphatic vessels or the lymph propulsion rates were much higher in women with stage 1 or stage 2 lipedema compared to controls, and even stage 3. So in early stage lipedema, there is not a failure of the lymphatic vessels. In fact, what the lymphatic vessels are showing is that they are getting a stimulus to pump more. And whether they're pumping the exact same amount of fluid, and that has not been measured, but I do think it is reflecting the fact that there's more fluid that's entering that interstitial space. And this is the paper that showed that the vessels were dilated. They showed some intravascular pooling. So the way the blood vessels looked was not exactly normal, but they were pumping at higher rates. So how does lipedema begin? So I think it begins with inflammation, and we don't know where the inflammation comes from. And I hope that you're stimulated to think about it and to look into it and research it and figure it out. But it could come from hypermobile joints and maybe micro tears. It could come from other genetics. And I know that there have been a couple of genes that have been proposed for lipedema, including just recently the MTHFR gene. Female hormones can contribute to weakening of the tissue, generating inflammation. Mast cell activation disease was proposed by Dr. Larry Afrin at the Fat Disorders Resource Society conference a couple of years ago. We know there's increased immune cells and macrophages. Could it be a specific type of macrophage that you inherit from your mother or your father? Could it be vein disease? Could it be leaky gut? Could it be all of this together? Once inflammation occurs, once inflammation occurs, you get stagnant fluid, edema, and fat growth. I have to, can't figure that out. Anyway, All right, so let's get into the compartments in lipedema tissue. So this is a picture from Dr. Simarro. Here's the skin on top, so epidermis, dermis. Here's the superficial fat layer, and then you have your superficial fascia here. That's one compartment. And then you have your deep fat layer and your deep fascia. That's a second compartment. So we already have two compartments in lipedema tissue, or anybody's tissue, right? But we're talking about lipedema today. And these compartments are actually very different. The top compartment, or the superficial sat, is actually healthier than the deep compartment. The deep compartment overexpresses inflammatory genes. So I think when we do research on lipedema, we need to remove fat from the superficial sat compartment and from the deep sat compartment and compare that to controls. I think mixing them both together in a lipedema, after lipedema liposuction is probably not the best way to study lipedema. So right now we have two compartments, let's say in the leg of a person with lipedema, but in all actuality, there are actually three adipose tissue compartments in the leg. So if we're looking at the medial leg here, we have our superficial sat here on the outside, our deep sat, but then we have a third compartment here, the saphenous sat compartment. And this is of the greater saphenous vein on the medial leg. And within that compartment, you have the greater saphenous vein, you have a superficial lymphatic vessel, and you have a nerve. And the deep part of that compartment is the deep fascia, and covering over atop that saphenous compartment is the saphenous fascia. So if you're looking at the medial leg, there are three compartments, and we think you can grow lipedema fat in any of these compartments. So let's look at it at a slightly different way. Here's your dermis, epidermis on top. Here's your superficial sat here. Here's your superficial fascia. Here's your deep sat here, and your deep fascia. Your deep fascia here, and your saphenous fascia here. Here's your greater saphenous vein, your superficial lymphatic vessel, and a nerve. And you could see that veins outside of the saphenous fascia drain blood into the saphenous vein, and lymphatic vessels that come all the way from the skin drain lymphatic fluid and pierce the saphenous fascia and enter the lymphatic vessel in the saphenous compartment. So this becomes a place where both venous blood and lymphatic fluid are being drained into this small compartment on the inner part of the leg. And this is what the greater saphenous vein compartment looks like. It's smaller on the calf, it's larger on the thigh, and within this compartment are a lot of veins. So you can imagine if you grew a lot of fat within this compartment, it would compress the veins and may cause pain. And we know that there is pain in lipedema tissue. So if you push on this compartment, it's probably going to be tender. We also know that lipedema fat is unhealthy fat, so it's secreting these inflammatory cytokines. If these cytokines are sitting within that saphenous compartment, those veins are sitting in an inflammatory soup, which may also contribute to the pain. This is a more anatomical look at what the saphenous vein looks like and where it sits in the leg, and you can see it comes up the leg here, all the way up the thigh. And then on the posterior part of the calf here is the lesser saphenous vein, or small saphenous vein. And I wanted to also show you a little bit more of an anatomical look at the greater saphenous vein in the fascia. And this is a very thin person, and I really appreciate the fact that they donated their body for research. And you can see the greater saphenous vein in here, and you can see despite the lack of fat tissue on the leg that there is still fat within this fascia compartment. So fat is an integral part of this fascia compartment. Now let's look at legs of women with lipedema again, knowing that maybe fat can grow within the saphenous compartment. And I think you're going to look at lipedema legs differently now. So doesn't this kind of look like a saphenous compartment to you on the medial part of the leg? How about over here or here? And you can see it's lower on this leg than here. And we think that often lipedema begins on the thigh and progresses down the leg as you can see here, and here there's an asymmetry, unclear why, maybe because the veins are differently affected on each side of the leg. So here's the lesser or smaller superficial saphenous vein on the back of the leg. It begins here on the lateral malleolus and extends upward to the popliteal space. And I'm sorry if I'm butchering the descriptions of these veins, my friends who are expert in vein disease, but this means that you just have to get more involved. So let's say that you increase fat growth within this lesser or smaller saphenous vein compartment. It is going to put pressure onto that smaller saphenous vein. That pressure is going to extend downward and push the venous fluid down towards the ankle. And pressure is going to be greatest towards the ankle. Now, a lot of women with lipedema develop that fatty pad on the outside of the ankle. And I've said for a long time, I think this fat pad is due to vein disease. I just don't know how. But I think now I do know how, and I think it's through an increase in adipose tissue growth within this small saphenous vein compartment, increasing pressure and increasing fluid extrusion into the tissue, causing fat to grow. Now let's look at the compartments again. So we're looking down on the leg, obviously, and you can see that you've got your gastrocnemius muscle here. You've got your soleus muscle here. You've got your deep veins here. You've got your small saphenous vein on the back side of the leg, and you have your greater saphenous vein on the medial side of the leg. And unfortunately, this isn't exactly anatomically correct because the saphenous compartment is not shown very clearly around either vein. But my point is for this slide that there are muscles of our calf that when they are contracted, they squeeze around the deep veins, pushing fluid up to the heart. The same is not true for the medial superficial vein or the posterior superficial vein, so the saphenous veins. So how do they push their fluid back up to the heart? So what happens is when the soleus and gastrocnemius muscles, which is your calf muscle pump, contract, because the deep fascia is part of the saphenous compartments, it actually causes those compartments to contract and squeeze the superficial veins. So that propels superficial vein fluid through to the deep veins, which then gets pumped up to the heart. And this is an example of just that. So here's your small saphenous vein compartment on the back of the calf. In relaxation of the muscles, you can see there's a nice plump, lesser saphenous vein compartment with its contents. But when you contract the muscle to squeeze those deep veins, it also squeezes that saphenous vein compartment, propelling fluid towards the deep veins. So we need the calf muscle pump to move fluid out of the deep venous system as well as the superficial venous system. Now, what happens in lipedema? This is what we are proposing. This is our theory, that in contraction, instead of that fascia squeezing and pushing fluid towards the deep venous system, it's not changing very much. And it's either not changing very much because of the fibrotic nature of the saphenous compartment itself, the increased amount of adipose tissue within that compartment, or a combination of both. And therefore that fluid begins to stagnate as well, and it is going to flow back into the tissue. So let's review. Subclinical compartment syndrome: increased pressure within any compartment in the limb, either the leg or arm. It happens slowly over time, not acute, and it compromises the function within the compartment. So the muscle, it reduces force generation, causes atrophy, causes it to become fatty and fibrotic. Lymphatic, it reduces interstitial space drainage. It causes stagnant fluid and fat overgrowth. The vein, it causes reflux of additional fluid into the tissue, causing stagnant fluid and fat overgrowth. Nerves, it causes pain and numbness. and arterial, it can cause reduced flow and capillary dilation and leakage. And this is sounding very much so like lipedema pathophysiology. So here's a very complicated diagram, and I apologize. Both Dr. Simarro and I like things to be very well detailed. So I'm going to just walk you through this real quick. Here's your calf muscle pump. Here's your deep venous system in between those two orange ovals. And the blue arrows are showing you that when that calf muscle pump contracts, it pushes fluid up towards the heart. To the left is your superficial saphenous vein. And the way it gets blood to the deep system is either through a direct perforator vein or an indirect perforator vein that enters the muscle compartment. If you cannot squeeze that superficial saphenous vein very well, you're going to get increased pressure, and fluid is going to flow back into the tissue, but also into the muscle. And if enough fluid goes into the muscle, that's not good for muscle. Remember, our tissues don't like to sit in fluid. That muscle is going to generate hypoxia, inflammation, fibrosis, and could lead to muscle compartment syndrome. And I think a lot of women with lipedema have muscle compartment syndrome. And in part, it could be due to this compartment syndrome theory, or it could be due to the amount of fibrosis within the tissue and of the fascia. Here's our look at our cartoon of the leg and the compartments, and you can see the greater saphenous vein on the medial side of the leg. And there are indirect perforators coming out of the vein into the soleus muscle and into the gastrocnemius muscle. And we think that this makes that tissue very friable. And when you palpate the medial part of the leg, we think part of the pain is due to muscle pain and the amount of fluid that has entered those muscle compartments through the indirect perforating veins. Now, the lymphatic system, again, a very complex diagram. So you have an extensive superficial lymphatic system. That's all the orange shown here. You've got superficial lymphatics in the skin, you've got it in the subcutaneous adipose tissue, and then you've got it in that saphenous sat compartment. And you can see there's no connection between the orange superficial lymphatic system and your deep lymphatic system. So if you're not squeezing that lymphatic fluid through the contraction of the calf muscle pump and that stretching or contraction of that saphenous fascia compartment, then that lymphatic fluid is also going to reflux back into the tissue. It cannot be taken up, it cannot be transferred over to the deep lymphatic system. So there has to be an alternative way that that fluid gets out of the tissue. So another way to look at it is on this slide. You can see that that yellow there is your superficial lymphatic system, and your deep lymphatic system is kind of that brown vessel shown there. And you can see there are not connections between the two in the leg. There may be one connection in Hunter's canal that occasionally connects them together, but in general, they're not connected. The only place they are connected is in the foot. And so we know that the deep lymphatic system can clear lymph from the foot, but not from the rest of the leg tissue. So if your superficial lymphatic system fails, your deep lymphatic system can remove lymphatic fluid from the foot. And maybe this is why the foot is often unaffected in lipedema. But that deep lymphatic system cannot remove the fluid from the rest of the superficial adipose tissue. Therefore, we think the fluid becomes stagnant and fat grows. So how does that fluid get out of the lipedema tissue or any tissue if your superficial lymphatic system fails? And we think that it leaves through an alternative route, and that is through the new interstitial organ, which was new back in 2018. And those are those fluid-filled spaces in all tissues, including skin, which is shown here, or the intestine, or the lining of your nasal passage. It really doesn't matter. All tissues have these fluid-filled spaces, and we are all connected from head to toe through that interstitial space. So if fluid is remaining in the lipedema tissue and it can't get cleared by that deep lymphatic system, because that superficial system has failed, it has to be cleared from an alternative route. And I think this is one of the reasons why we say that women with lipedema need an advanced pump. We need to pump their legs, but also their pelvis and their abdomen, because if we just pump their legs, we move the fluid up into their abdomen. Well, how is it getting there? It's probably getting there through this alternative pathway. So what proof do we have? So this is a transverse section from the leg of a woman with lipedema, and thank you for donating your body. And you can see that here's your small saphenous vein here. This is the small saphenous vein compartment. And here's the skin. And this is the rest of the fat tissue on the leg. And you can see that the fat in the small saphenous vein compartment is taking up almost all the leg, over half the leg, compared to the fat in the superficial and deep sat compartments. And you can see here that the vein is not very enlarged, but you can see out towards the periphery that there are some larger veins that are a little bit more dilated than they should be. So could it be that there's increased pressure within this compartment, pushing fluid up to the veins near the surface of the skin, causing them to be dilated? And is this compartment syndrome that we're looking at? And here's an ultrasound. And I can do this. I've been doing this recently. I can see the superficial saphenous vein compartment. I can see the greater saphenous vein compartment. And you can actually see the superficial saphenous vein and the compartment clearly, and the two fat layers above it. And so I implore anyone who's doing ultrasounds or who is working with veins to, collect some data and see if we can prove this theory right or wrong. And I'll go either way, because the more we learn, the better. This is a picture courtesy of Dr. Jamie Schwartz. Thank you, Jamie. And he is showing us here tissue in the leg of a woman with lipedema. And you can see here the fat and the surface, and then you can see the deep fat, and you can see how fibrotic it is. So this is deep fat near the deep fascia. So could it be that that fibrotic cage that develops in lipedema, especially deep, is causing contraction of the compartments, both muscle and saphenous, inhibiting normal flow of venous fluid and normal flow of lymphatic fluid? And this is another example where he's actually going down to the deep fascia. He's opened up the deep fascia here, and you can see what's coming out as fat. And so we think that in lipedema, fat completely grows through the deep fascia, through the superficial fascia. That fat is around muscle and also within the saphenous compartments. So is there any evidence in the literature of compartment syndrome and hypermobile joints? And there are a couple of papers on vascular Ehlers-Danlos syndrome and bleeding into the compartment. And there's also a more recent paper on compartment syndrome developing in a woman with a mixed connective tissue disease resembling hypermobile Ehlers-Danlos syndrome. So I think we have some data showing that compartment syndrome most likely can occur in lipedema, and some data showing it can occur with hypermobile joints. But obviously we need more than case reports. So going back to our pathophysiology, how does lipedema tissue begin? With inflammation. So again, we talked about all different sources of inflammation. I'm sure you can think of more. And I think hypermobile joints should definitely be on the spectrum, but also I think leaky gut is also important. This inflammation contributes to leaky blood vessels, but hypermobile tissue could do that too. Fluid becomes stagnant, fat overgrows, and you get compartment syndrome. And this can happen in muscle compartments or in fat compartments. So both in the superficial sat, deep sat, or the saphenous sat. If we propose that if the fat overgrows in the superficial fat and the deep sat compartments, that there could be a lot of tissue, but maybe less pain. But if it grows within the saphenous sat compartment, because that compartment is very limited in size, and it's full of nerves, that you're actually going to get more pain with less tissue. And if you grow fat in all three compartments, you're going to have more pain and more tissue. So I think this offers an explanation of different presentations of lipedema. So there are two phenotypes that have been described for lipedema. The first is the Allen and Hines phenotype back in 1940, and that's lipedema A shown here, and that's with a relatively thin ankle compared to lipedema tissue on the thigh. And in this case, we think that the superficial sat and the deep sat are hyperplastic early on. So this is a young woman who at the time of puberty notices that her hips, thighs, and buttocks have become large, but she doesn't have a lot of pain. And she goes throughout her life and encounters stress and different foods and different environments. And over time, this fat is releasing inflammatory cytokines that enter the venous and the lymphatic stream. They eventually reach the saphenous compartment and they inflame those adipocytes, which begin to grow. And this triggers the subclinical saphenous compartment syndrome. And then the fat and pain begin to spread down to the calf tissue as shown here. That is different from the second phenotype, which is the Moncorp's or rusticanus lipedema phenotype shown in B. This was also first described by Moncorp's in 1940. And it's where you have the subclinical saphenous compartment syndrome first. It's present from the start. So inflammatory fat is growing within that saphenous compartment, and the ankles have that tubular shape. So this is the cankles, and young girls with cankles, where the ankle is the same size as the calf. And due to retrograde pressure, lipedema begins to spread up the leg. This is often accompanied by valvular venous disease, contributing more fluid to that interstitial space, and you get that pantaloon appearance of the leg. And this type of lipedema may explain lipedema stage 0, where you don't see lipedema tissue on the leg of a girl, but she has pain. And this could be an inflammation within that saphenous compartment. So can other diseases other than lipedema have compartment syndrome with the same pathophysiology? And I would say yes. I think this compartment syndrome definitely occurs in lymphedema. I also think it can occur in other forms of obesity. So we are not saying that compartment syndrome is exclusive to lipedema. What we're saying is that there are some things contributing to a specific type of inflammation combined with the female sex that is causing fat to grow in different compartments. And depending on the compartment it grows in, it can present in different ways. And you can also see that if you develop lymphedema, it's going to worsen lipedema. If you develop obesity, it's going to worsen lipedema. So how do you diagnose compartment syndrome? Never been done for lipedema to my knowledge. Obviously, it's been done for hypermobile tissue. And this Pedowitz criteria is for people who have exertional chronic subclinical compartment syndrome. So where their muscles are swelling because they're elite athletes or they're overexercising. And they measure a resting pressure greater or equal to 15 millimeters of mercury. That's compartment syndrome. Or greater than 30 millimeters of mercury 1 minute after exercise, or 5 minutes after exercise greater than 20 millimeters of mercury. And you can see the device that's used. It looks a little bit painful. You're poking into a compartment, but certainly this can be done for lipedema, and I hope somebody takes up that challenge. So how do you treat it? So I think primarily what we're doing for lipedema anyway is you're reducing inflammation. You're eating anti-inflammatory foods. You're exercising the calf muscle pump. You're using anti-inflammatory supplements and medications. Stress reduction to reduce activation of mast cells. Anti-inflammatory injections might be a possibility. Don't know. You should ask Dr. Simarro what he does. And lipedema reduction surgery may treat compartment syndrome. And in fact, a lot of Dr. Schwartz's patients say that after they've had their lipedema reduction surgery, for the first time, they feel their muscles engage. What about stretching? Shouldn't we have some sort of stretching program to keep our fascia around our compartments flexible? Physical therapists and occupational therapists, should you be treating myofascial restrictions? Should you be improving neuromuscular function? Deep tissue therapy. We've already talked about in many PowerPoint presentations and many conferences, instrument-assisted improvement of lipedema tissue, including foam or flat rollers, lasers, gua sha, negative pressure therapy. I think that intermittent pneumatic compression pumps are important, and they need to treat deeply into the tissue to get those deep saphenous compartments. I've noticed that a lot of my patients stand improperly, especially if they have hypermobile joints. I think posture is important. Orthotics could be helpful. You can hear my Chicago accent. Orthotics can be helpful. But if you don't have good posture, you don't have good chi flow, and that chi flow is through that interstitial space. I think fasciotomies would be a last resort, but especially with lymphedema, they may be an option. Should we be breaking up the tissue with cavitation or shockwave therapy? And what about vein treatments? What role do they play? Now, this is an example of deep tissue therapy to treat subclinical compartment syndrome. This looks way different than manual lymphatic drainage therapy. And you can see that they're putting a lot of pressure into that calf muscle pump. So I think we may, if we believe in compartment syndrome, need to rethink how we do manual therapy. So compartment syndrome and lipedema. It begins around the time of hormone change. How do hormones affect adipose tissue in the compartments? Are there different hormone receptors in different compartments? I don't know. Let's find out. Inflammation causes adipose tissue growth and leaky vessels. Where does the inflammation come from? Is it an inherited defect in the immune system? Do we get a specific inflammatory gut bacteria from our parents? Is it an inherited defect in the fascia? It may be affected by many genes that affect connective tissue in the fascia. And it may manifest differently depending on what compartment is affected. And you can imagine that if the superficial sat and the deep sat are different compartments, and the deep sat is more inflammatory, that saphenous sat compartment fat may also be different. What are non-surgical treatments of compartment syndrome? I think therapists play a key role by changing the tissue environment. How can we improve flow out of the compartments? Maybe the therapist should get an ultrasound machine and follow the size of the compartments before and after treatment. It's not hard to do. Have your bosses buy you one. Should we be using deep tissue therapy versus MLD versus laser versus shockwave therapy versus cavitation? What is the right treatment? We need samples of tissue from all the compartments. I think mixing up fat from all compartments in a lipoaspirate is not targeted science. It's not the best. And can we inject anti-inflammatories in the compartments to reduce compartment syndrome? Don't know. And you vascular surgeons and phlebologists, how does closure of chronically refluxing veins affect the physiology of lipedema if compartment syndrome is present? Should the perforator veins also be treated? And what about treating other veins or tributaries? I think we must view lipedema as a disease of compartments and their contents and not just fat tissue. Thank you so much.
Dr. Herbst, there was so much there, and chat has exploded, as has the Q&A. We want to thank everybody who logged on for this, and I will underscore the fact that this has been recorded. It will be posted on our YouTube channel for Lympha Press, on our website, and everybody who is registered will receive a link to the replay. So you can rest easy that if you didn't get it all in one sitting, you'll be able to watch it again, and tell your friends as well. They can watch it too. Medical professional, Dr. Simarro himself. out there today washing, and you had mentioned him several times in your presentation. Dr. Wright is out there, Kathleen Lisson, Catherine Sayo, so many. And if I didn't mention your name, forgive me. We're so honored that you're here. So we have questions from medical professionals, and we have the patient population that is hearing what you're talking about and having aha moments. They're saying things in chat about hypermobility. Oh my goodness, I get it now. The vein connection, so many different things. So first of all, from everyone, a huge thank you, Dr. Herbst. We appreciate you laying this out for us. And I'm going to go through the questions one by one here, and they do run the gamut from medical professionals to patients. Sharon Robertson asks, since there is inflammatory angiogenesis, do lipedema patients have elevated VEGF? Are there other cytokines that are elevated?
So there's been a couple of papers that have shown elevated VEGF levels in lipedema and also lymphedema. There's some papers that say that lipedema is inflammatory. There's some say that it's not inflammatory. There is one publication that I cited showing elevated cytokines. I don't think we have a specific cytokine that's elevated in lipedema, but I will say if you have elevated VEGF levels, you have leaky blood vessels and you have leaky lymphatic vessels. So I think that those elevated VEGF levels are a marker of and not only angiogenesis, but the creation of leaky vessels. And where are we taking those samples from? So again, that it really makes me say, okay, well, there may be elevated VEGF levels, but where are they coming from? What compartment? And is that even important?
Interesting how the questions are like pulling a thread, and yet more questions come out of it. But I now learned that I need to say VEGF instead of VEGF. So thank you for that. I learned something today. Now, here's another phrase that I may not pronounce properly, so forgive me, everybody, in advance. Angela White wants to know if there's any connection between lipedema and levator reticularis.
Levator
I butchered that.
No, you
Thank
didn't.
you.
You did. Levator reticularis. So that I do think in some cases there are. I do have some patients with levator reticularis and with lipedema, but many that don't. So I don't think it's 100%. And if you look up levator reticularis, it's dilated venules. And so if your venules are dilated, why are they dilated? Well, maybe the larger vessels are dilated, have increased pressure, and are causing fluid to back up to the skin, causing those small venules to be dilated. Maybe there's a problem with autonomic function because the autonomic nervous system controls the caliber of vessels. So there could be something there. So I don't think it's a one-off. There could be different reasons to get levator reticularis, but I do think it's a microvascular problem. And if you look at lipedema tissue by ultrasound, you see that there are a lot of thickened small vessels. So I do think small vessels play a large role in lipedema, but I don't think it's always levator reticularis.
Gotcha. Thank you so much for that explanation and for the great questions. So many of them. I'll keep going. Tina Kunkel wants to know, does Lasix help to get rid of the fluid then?
So don't like Lasix. Only use it if you absolutely must. And the reason for that is that Lasix pulls sodium and water out of the tissue. And I did show that interstitial space with the connective tissue and the proteoglycans that bind up fluid and also bind up sodium. What happens is if you pull the water out of that interstitial space, those proteoglycans, which are bound up to water forming a gel, get dried out and thick. And then more water enters the tissue and your body says, I need more proteoglycan. So it makes more. And then you pull that water out and those add to that thick gel in that interstitial space. And then you don't get good flow through there. So you're basically creating this thick, hard, gooey gel in the interstitial space the longer you're on Lasix. And in fact, Peter Mortimer's group showed that the fluid in that interstitial space is not high protein. It's high in glycosaminoglycans or sugars, which make up that proteoglycan molecule. So it is a thick glue. So you don't want to do that. So if you can
Thank
not
you.
be on Lasix,
Excellent.
great. If you have to be on Lasix, you have to be on Lasix. I mean, that, that's between you and your doctor to work through. And other diuretics. So I have had patients who are on like hydrochlorothiazide or things that help with blood pressure, and they seem to do okay.
Okay. So there's a lot of curiosity about which came first, the inflammation or the lipedema. Angela White asks a follow-up. For the initial inflammatory event, might having autoimmune conditions be the triggering event leading to the development of lipedema?
Yeah, I mean, we don't know, is lipedema an autoimmune disease? Is there something different about the immune system that is causing inflammation, I would say, or causing fat to grow? And I have done that chicken and the egg thing. I've done like, oh, it's got to be the fat cell. There's something different about the fat cell, and that's what's causing this, and that's generating the inflammation. And then I go, oh, no, it's got to be the inflammation that's caused. So I've done that myself. Well, I don't think we have the answer, but right now I'm leaning more towards there's some sort of immune dysregulation generating inflammation, and that's causing the fat to grow. Now that fat growth is secondary.
What's it like to be in the hot seat? You never know what kind of question's going to be thrown at you next, and you handle them all with such grace, Dr. Herbst. We are truly appreciative of it. Teddy Bradford, here's a completely different question and very interesting. Teddy is wondering about toxins, dead debris, etc., from other illnesses like Lyme disease in this particular instance. Can they be released during lipedema treatment? For this particular participant today, recently found that they are in a big flare of two biggest tick-borne symptoms, head pain and fatigue, since doing physical therapy. So the question is in the treatment of the actual lipedema, is it releasing stuff that's creating more problems?
I have patients who go in for their first session of manual lymphatic drainage, and they say, oh my God, I felt so sick when I slept for 2 days, and I can't do that. I can't do that anymore. And basically what that tells me is that you have such a high level of inflammation, and you perturb it, and your body's trying to contain it, but then it gets released, and then your immune system reacts again to that. So could you, yeah, sure. Anytime you add more inflammation, it's going to worsen the lipedema. So, and we've published on Dercum's disease and infection, and it's sounding more like the Lyme Dercum's disease connection. But I would say if you've got lipedema and you can't handle MLD, you should be focusing on getting your inflammation down. Get your blood tested, do blood tests, CRP, ESR, D-dimer, CH50, find out what, if you are inflamed, find some sort of marker that you can follow, and then work with your healthcare provider to get your inflammation down. Eat as healthily as you possibly can. That just means no processed food, avoid processed carbohydrates and sugar. Move as much as you can. And if you can't move very much, get in the water, sit down and put your feet on a whole body vibration machine, do something. But I think getting that inflammation down and then go back to that MLD and try it again. And as you progress through MLD, then you can get into deeper and deeper treatments.
Yeah, that's really a great answer. And it's interesting, many of us have done detoxes and we feel worse before we feel better. So I also want to make a note and put in chat here. First of all, a lot of you are putting questions in chat. I'm plowing through the Q&A. I want to get to your questions. So if you really want me to get to your question, put it over in the Q&A so I make sure I don't miss it, because chat is very active and I don't want your wonderful questions to get lost in the shuffle. I also want to let everybody know we offer this kind of amazing content every month on the educational webinar platform for Lympha Press. Lipedema Awareness Month is always very special. And Linda Ann Kahn is presenting for us on the 22nd. The issues are in the tissues. There's a link in chat. Grab that. You can sign up for any of our events, including our lymphedema and lipedema patient roundtables. we love supporting the patient community and we love supporting the medical community. Together, we link arms, we make it advance, we learn, we grow, we help. That's what matters. Okay, here's a very lengthy question that I'm going to read from Siobhan Huggins. We're so glad you're with us, Siobhan. Dr. Herbst, she's wondering if you've looked in depth into the similarities and differences between de facto lipedema and the lipedema-like phenotype seen in around 30% of those with Williams syndrome.
Mm-hmm.
They do have the disproportionate fat growth and gynoid areas, the cuffing, aortic stiffness, possibly an elastin deficiency, but they do not have the easy bruising, pain, or from an initial email to a research team, possibly not the fibrotic nodules. Do you have any thoughts on this, perhaps related to elastin deficiency, connective tissue laxity versus perhaps connective tissue fragility in lipedema or something else? She's very curious about the nodules, especially because they seem to be distinctive of lipedema and may provide further clues as to what's going on. She also had in a subsequent note, thank you so much, Dr. Herbst. You've given us something to really think about here. I think that's collectively from the audience. That was a main question. If you need me to go over any more of it with you, your initial thoughts on this?
I do know Williams syndrome, and I amazingly, I've seen the legs of people with Williams syndrome, even, the males have legs that can look like lipedema, and they're missing 1.5 million base pairs, and within that region is the elastin gene, but we haven't seen that mutation in lipedema. So I think there's all different ways to get to compartment syndrome. I don't know if they've looked at compartment syndrome in Williams. We haven't even really looked for it in lipedema very much. So again, this is just a theory. It seems to be very reasonable. It seems to explain a lot. And in the beginning of my talk today, I did talk about how women's tissue is weaker, more stretchy. The fascia, is thinner, and could be the same thing that's happening in Williams syndrome. So they, again, we can learn so much from other diseases. And I did think about adding Williams syndrome in here, but I thought, nah, I'm sticking to lipedema. But another, great, and I should look again. I haven't looked at Williams syndrome for a long time. So thank you. I'm going to look at it again and see if they've looked at the vein compartments.
Excellent. Jenna Baker has a question. Does compartment syndrome seem to be symmetrical most of the time?
It does seem to be symmetrical most of the time. Yep. But, we do see, if you look at women with lipedema, there's differences. There's some asymmetry. And I think I showed some of those pictures today. You could see some of the asymmetry in the legs. So it's not exactly symmetrical all the time. Veins are not exactly symmetrical from one leg to the other, nor are lymphatic vessels. They're mostly symmetrical, but not exactly. And if you read about any kind of arteries, veins, especially in the pelvic area, they tell, the differences between the right and left side. That could contribute. In fact, how does pelvic congestion syndrome contribute to lipedema? That's also a venous problem that we, don't talk about very much, but it comes up over and over in my patients, and I'll say, maybe you have pelvic congestion syndrome. Let's take a look at that. Your veins are abnormal in your legs. They might be abnormal in your pelvic area. How does that contribute to compartment syndrome? Don't know.
Okay, so Marty Dietrich has a twofold question. Number one, does lipedema tissue weigh more than normal fat?
Nobody's weighed it, but fat is supposed to be light and fluffy. And when I palpate bones, I always go, ooh, nice and fluffy, good job. But if it's like really heavy, I say, ooh, okay, this is a problem. We got to take care of that. We got to get compression. So, and yes, Kathleen, listen, compression is important in compartment syndrome, because I'm answering that question too. But I do think it can be heavier than normal fat, but not all the time.
It's so interesting because we had a research roundtable just this month for Lipedema Awareness Month with Dr. Jamie Schwartz, and he was showing video of the lipedema nodules. And, you would think it's gotta weigh more because it's so much more dense and
Mhm.
it completely looks different.
Yep.
Normal.
Yeah. So the
fat.
heaviness can be from fluid. It can be from fibrotic tissue.
Mm,
And I've been looking at by ultrasound at the arms, big arms, and you see that the veins are dilated. So you've got more fluid in the veins, maybe
mm.
more fluid in that interstitial space as that glycosaminoglycan proteoglycan gel. And then you have all that fibrotic tissue.
Yeah. So part 2 of Marty's question is, does moving from stages of mess with your metabolism? Did I
Wow.
freeze
Okay.
there? My internet connection seems to be a little bobbly, so I apologize for that, but I hope you got that question.
Yeah. So does moving from stages significantly mess with your metabolism? I think the metabolism of lipedema tissue is off just in general because of the hypertrophic fat cells. The more lipedema tissue you have and combined with maybe some non-lipedema tissue, absolutely make it worse. So the goal is to keep your, regular fat tissue down as stable, at least stable as much as possible, and to reduce inflammation as much as possible. But anything that generates more inflammation is not good for lipedema.
Bottom line. Joe Salisbury, post-presentation question. Dr. Herbst, you mentioned the MTHFR gene. Is there an official way of saying that?
MTHFR is perfect.
Good.
Methylene tetrahydrofolate reductase is not a great way to say that.
Right.
So there's
regarding lipedema, you mentioned that gene. Are there any new findings, or can you comment on those findings?
So there is a paper that just came out, and I'm sorry I don't have the citation on hand, but if you search for it online, you'll find it right away. And they have associated mutations in the MTHFR gene with lipedema. And, there's no physiology, there's no, so all that work needs to be done, but I think it's a good first thought. And as you probably also know, the mutations in the MTHFR gene have also been associated with hypermobile Ehlers-Danlos syndrome. So we've got 2 reasons why I think every woman with lipedema should have her MTHFR gene assessed. And I've just been doing that over and over and over.
Questions about fascia blasting tools. A name brand was named here, Ashley Black. Any thoughts on, we're not advocating for any particular device, except of course the Lympha Press, but I'm advocating for that. It's so interesting. Some of our people that logged on were actually pumping with their Optimal Plus while they were watching you talk. And I love that because you specifically mentioned that you need to get into the deep, higher pressures, which not every pneumatic compression pump offers those pressures. So that's why the Optimal Plus is so effective, reducing pain, increasing mobility. In some places, fat pads disappear. We've had great results. If anybody wants to know anything about that, please reach out to me personally, bviola@lymphapress.com. Little commercial there, had to throw it in. But what about the fascia blasting tools, Dr. Herbst?
So I have never used a fascia blasting tool. Our goal with treating the tissue is not to blast the fascia away. It's to improve the quality of the fascia. What I like to recommend is that you start treating slowly into the tissue. You don't go deep right away. And it seems to me like the Ashley Black fascia blaster, the goal of it is to go deep really fast. And I just don't think that's healthy for lipedema. And I would rather you use something like a flat roller or, manual therapy or a different kind of foam roller. And then you could go deeply into the tissue and use something like that tool. But I just don't like the word fascia blaster. If it said fascia improvement tool, I would be all for it, but that's not what it says. So I think it means that you want to blast away the fibrosis of your fascia and make it all smooth and nice and flowy. And that's what we want. But I think you have to do it slowly because you don't want to cause damage. And I did see a lot of pictures on the internet of women who have fascia blasted and got a lot of bruising. And, you know, that may be good or bad. I don't know. Where's this? I don't know.
Wow.
I don't know.
Yeah.
What happened to them?
Interesting. South Jersey native here, fascia is what comes out of my mouth when I know fascia is the correct pronunciation.
I
But
say fascia.
regarding fibrosis, fascia, you say fascia, I say. So deep oscillation therapy, is that helpful to soften fibrosis?
I think so. I do think any way to treat deeper into the tissue in a safe manner is, you know, absolutely yes. And my questions were like, there are some publications on shockwave therapy for treatment of lipedema and that it was as effective as lipedema reduction surgery. You know, I think we need to repeat that, but anything that improves flow through the tissue in a safe manner, yes. And oscillation therapy has been used for years and years. And so I support that.
Excellent.
And there's another
Go ahead.
question I see. Would you expect then that a patient that had compartment syndrome acutely on one leg would have an asymmetry in their lipedema? I would say, yeah. I would say yes, for sure.
Okay. That was exactly the question I was going to next. So then we'll go right on to, well, gua sha, and we already just talked about fascia blasters. So we did answer that. What happens if GSV is ablated? What happens to the fluid?
I would love,
thank you.
are there any vein doctors still on? Because I would love for, you know, someone with experience in treatment of veins to answer that. You know, raise your hand. Can we call on somebody?
Yes, yes, we can. If somebody wants to raise their hand, we can definitely call on them. Keep going in the interim though. What is the potential role of frequent MLD 2 to 3 times a week? And based on the deep SAF conjunction, should deeper tissue MLD be indicated? Emma Cloney, thanks for the question.
I think that manual lymphatic drainage therapy plays a role in treatment of lipedema, but I also think that deeper tissue therapy also plays a role. And I think that's between the therapist and the patient about when that occurs and what is done. And if somebody cannot even tolerate manual lymphatic drainage therapy, why are you going deep? But if someone says manual lymphatic drainage therapy is not helping me at all, shouldn't you go deep?
Asks related to the new research, and actually every slide of yours had citations on it. So you can see the presentation in the replay and see all the different citations. Mary, you've done extensive research to come to the new theory, Dr. Herbst, and we appreciate the time put into it. I hope that's your question, Mary. Definitely you can check out replay. The PowerPoint is complete with the citations that support this research. A big thank you from Shannon Misiazek. I'm not sure if I pronounced that correctly. So many aha moments. She says she feels like her leg muscles are atrophying despite how much she exercises and lifts, like her fat is blocking their ability to grow, but it makes sense now.
Mm-hmm.
You know, isn't it just so comforting that things can make sense? You may not have the relief yet or the answers, but at least you have the understanding.
And it gives us, you know, whether this theory is true or not, I think this is why we do these talks. We do these talks to stimulate your brain to think and take the next step. And even if we're not exactly right, it's okay. I think it makes us progress in this field, and that's what we need to do, and we need to do it fast.
So acupuncture, we talked about a lot of different tools here. How do you feel about that? Acupuncture helping the flow?
So I've anecdotally heard that it saved, you know, a patient's life, that she could not have done all the deep tissue therapy that she did without acupuncture. But I've also heard that like some people can't tolerate it. So, and then everything in between.
Mm-hmm.
So I think acupuncture would be great to try, because I think that it does help move chi. So if you have the opportunity, I would not say no. I would give it a try.
And you've just done underscored something really important. We say this at all the patient roundtables. What may be fantastic for one person may not be for another. It's not one size fits all. It is listen to your body, most of all, patients. And so speaking of the medical professionals, Tina Kunkel wants to know what kind of doctor you go see to get the correct diagnoses.
So, I mean, for lipedema, you know, the vascular doctors are becoming more and more knowledgeable about lipedema. So a vascular doctor would be a really good resource. And then, you know, word of mouth from about other doctors who have taken up an interest, you know, like I'm an endocrinologist, I'm not a vascular doctor, but, and then for compartment syndrome, you know, that is a surgical emergency when acute. And so the surgeons are the ones that are going to have the devices to measure compartment syndrome. And I don't, you know, or like an orthopedic surgeon, but I do think it's going to be a surgeon who's going to be able to do that for you. Or if our vascular surgeons and phlebologists would help us collect data on the size of the compartments, they may be able to tell you whether your compartment is enlarged or not by ultrasound. And I really truly think that physical therapists should have ultrasound machines.
Okay. We've gone 15 minutes over. How are you on time, Dr. Herbst? Can we continue to take some questions here?
Sure.
You're awesome. We appreciate you. Okay. Anonymous attendee, this is a great question for all patients. And I think that you have a standard answer for this, but let's do it. How do you recommend patients to advocate helping their medical professionals to understand more about this? How do we ask for our medical professionals to learn more without being seen as someone with
a fictitious disorder?
Fictitious disorder. Yes. Oh,
yeah.
We feel
lipedema is not real. That's an internet
diagnosis.
diagnosis.
Yeah, right. Well, the standard of care for lipedema in the United States, which we applaud, it's on the Lympha Press website. It's on many different websites, spearheaded by Dr. Herbst, an amazing team of authors, is a great thing to march into any medical professional with, but I won't steal your thunder. How would you answer this question, Dr. Herbst?
That's what I would say. And within the standard of care is a list of standards of care from other countries. So it's not just us.
Can lipedema have an effect on diabetes? Ann Maddox wants to know.
Yeah, I would say yes. I would say if your lipedema is inflamed, I mean, it's in that high inflammatory state, it can definitely worsen your diabetes. And if your diabetes is in a high inflammatory state, it can worsen your lipedema. So I think it's a two-way street there.
CRP levels. Do lipedema patients tend to have high CRP levels?
It depends. So a well-controlled woman who has lipedema may have a normal CRP level. Somebody who's in an inflammatory state, and for example, she's got a lot of allergies, or she's got mast cell issues with POTS and EDS, and she's having a bad time with a flare. Her CRP may be elevated, but in general, I would say that you're not going to see high CRP levels on a standard clinical test. You're sending it into a lab and they've got a normal range. You're not looking at a lipedema population and comparing it to a control population. It's not research, it's clinical care. And so often we find that CRP levels in women with lipedema fit within that normal range.
Connection between Castleman's disease and lipedema.
I have not heard of a connection between lipedema and Castleman's disease, but if there is any kind of inflammation in Castleman's disease, that could worsen lipedema.
Autoimmune diseases hereditary.
Autoimmune diseases can be hereditary, but they also may not be hereditary. You can either inherit a mutation from a parent. And in fact, at the Fat Disorders Resource Society conference in April of this year, I talked about autoimmune lymphoproliferative syndrome, which is a mutation in the FAS gene, which normally is supposed to cause lymphocytes to die off. But if the mutation is in that gene, the lymphocytes don't die off and they wreak havoc and cause a lot of autoimmune disease. You could inherit that from your parent, but you could also develop a new mutation at birth. And so in that sense, you may not have inherited it from a parent. So it can go either way. And in fact, some immune cells can actually change their genetics if they're stimulated over time via chronic inflammation. So that would be another way to develop an autoimmune disease. So yes and no.
These are common questions we get at the lipedema patient roundtables regarding Mucinex and Ozempic for lipedema pain.
So I've seen some women benefit from Mucinex and others not benefit from Mucinex. I've seen Ozempic amazingly reduce pain of women who have inflammation associated with lipedema. And I've seen it not reduce pain, but reduce fat. So I think it's very specific to the person, but I do think both can be useful, and definitely work with your healthcare provider to make a decision on whether they're appropriate for you.
We have just birthed a brand new mini series called Ask Dr. Herbst, and we're going to take every one of these questions and put them into little bite-sized pieces that you can digest on social media, because these are rapid fire questions and you are giving us great answers. We're so appreciative. I'm going to start from the bottom up here. Jewel Dukes, we appreciate you. You attend so many of our events. She wants to know if there's any info on cortisol and lipedema.
No.
Okay, there you have it. That was a quick answer.
Yeah, but that is a huge interest of mine, because when people are under a lot of stress, their cortisol levels go up. And in order to make your cortisol can weaken tissue, and that would not be a good thing for lipedema. But your cortisol levels go up because your corticotropin releasing hormone from your hypothalamus goes up. And that drives ACTH from the pituitary, which then drives cortisol from the adrenal glands. Your CRH directly activates your mast cells. So having stress weakens your tissue and activates your mast cells, which are part of your immune system. And mast cells make vessels leak. So not good. Stress is not good for lipedema. I think we should have a daily or weekly anti-stress call.
Yeah, and breathing exercises. Kathleen Lisson walked us through some breathing exercises recently, and I still go back to the box breathing every now and then, because lipedema or not, we all have stress, and medical professionals who are treating patients have stress. Remembering to breathe. Okay, vibration plates or like the Theragun style percussion. They're two different things, but I figured I'd put two questions in one right there for you. Two birds with one stone. Vibration plates or Theragun style percussion.
Both good. Just you want to be a little careful with your Theragun or your whatever, your muscle massager. Because if you have dilated vessels or you have a really sensitive area, you could hit it with the gun. But in general, my patients with lipedema tell me it feels really good. It feels really good to people who have hypermobile Ehlers-Danlos. So I think it's a great way to treat your tissue. I just won't say it's perfect for everybody and for all tissue.
Right. Gotcha.
And whole body vibration,
Ketoprofen.
yes. Ketoprofen is a great anti-inflammatory, and from work out of Stanford, it is supposed to promote lymphatic pumping as well. So I think it is a good alternative to some of the other non-steroidal anti-inflammatories like ibuprofen, because ibuprofen can cause edema, so it inhibits lymphatic pumping. So it is a good alternative. Sometimes it's just really hard to get. And there's a 50 milligram, 75 milligram, and 200 milligram extended release version. Some pharmacies have none. Some only have the 50, some only have the 75, some only have the 200. So it's kind of a difficult medication to work with sometimes to prescribe.
Okay. And that answered a few questions that were in queue. So thank you for that, Dr. Herbst. What about statin drug use? Does this have negative effects on lymphedema and lipedema, statin drug use?
Yeah, so I looked at statins a while back, and what statins can do is stabilize your blood vessels to make them less leaky. So in that case, I think it's a good thing. But some women have had problems with their muscles, problems with their brains, taking a statin. So I think that's something that you really have to weigh. You have to look at all the side effects and make a decision on whether to use it or not, especially if you're a woman.
Emma Cloney touches on something that I know is actually near and dear to your heart and many of the people involved with treating lipedema, getting early pubescent youth attention before it progresses. And there's got to be answers for that. But her question specifically is about insulin resistance, yet a low incidence of DMII, I believe that's the way you say it. Should we be using medications like metformin and GLP-1 medications as early prophylaxis, possibly in early pubescent youth?
Wow, that's a great question. There are side effects to GLP-1 agonists, slow gut motility, nausea, decreased appetite, and metformin can cause diarrhea. So, gosh, it's really hard for me to get super enthusiastic about giving medications to, young women. I think but both metformin and the GLP-1 agonists are anti-inflammatory. Can we come up with something else that we can treat these young women with that doesn't have those kind of side effects? I would prefer that. And obviously that's going to take a little more research.
Yeah. So I want to begin addressing Sheila Chamberlain's question, and please jump in, Dr. Herbst, because you are the expert. She says, it sounds like you're recommending all people with lipedema to use a Lympha Press. And forgive me, I get excited about our product because I've seen it work with so many people. I'm not making any blanket statement saying everybody who has lipedema needs to use a Lympha Press, but definitely look into it. Pneumatic compression is proven to be helpful. And certainly you can't get it without a doctor's prescription. If your doctor is not advising it, then we absolutely respect that. Mm-hmm. Now, not every doctor is well-versed in what the Lympha Press uniquely offers. So we would be happy to work with you and your doctor's office to help educate them about what the Optimal Plus offers that is different from any other product on the market. But when do you recommend a Lympha Press or pneumatic compression therapy, Dr. Herbst?
So I recommend a variety of different pumps to my patients based on their preference. So I kind of introduce pumps, what they do. I show them different pumps and kind of base it on, what they want and how they feel. And I'll recommend a pump to a woman who has a lot of fluid in her tissue, who has a lot of pain in her tissue, and especially one who can't get to a therapist. And I am amazed at how many women with lipedema live in the middle of nowhere, and they don't have a manual lymph drainage therapist or even a physical therapist that could help them within 50 miles. So I say, you know what, you need tools to take care of yourself at home. Let's go. And a pump can definitely be one of those tools. Not everyone needs a pump, and we're not saying that everyone needs a pump, but it is definitely a tool that empowers a woman to take care of herself at home when she needs it.
Yeah, it empowers them to do their own therapy at home. Not to say that we take the place of the amazing therapists out there. In fact, we work hand in glove with therapists so that what you get when you go to your therapist's office, you can maintain it when you go home. And it is a perfect complement to your therapy. So again, if you want to find out more, we'd love to answer your questions and work with your doctor's office. Thanks for that explanation, Dr. Herbst. Okay, we're going to do a hard cutoff soon. I promise you, because you could be here till tomorrow. Recommended treatments for leaky vessels and veins. Cynthia Mason wants to know.
So there are a number of different bioflavonoids that you can use for veins and that have been proven in the literature. Someone told me about a new one today, red vine leaf, I think. And I looked it up, and sure enough, there are some publications on it. But horse chestnut seed extract is well known to decrease inflammation of veins. Diazepam is also well known to decrease inflammation of the veins. You definitely want to make sure you have a good product that's well absorbed into the body. And then there's another one, Arteriocel, which protects the glycocalyx inside of vessels to decrease leakiness. And Mark Moline would know a lot about that. So again, bioflavonoids.
Bioflavonoids. So people want to know how to get a hold of you. You're no longer at Arizona University. Katie Taylor's like, so where are you now? How can we get a hold of you? What would you recommend for people that want follow-up?
So I am at Total Lipedema Care. I work primarily here in Tucson, Arizona, and you can just call us at 310-882-5454 to make an appointment. I'd be happy to see you.
Excellent. Here was a really good question. We've had a lot of people say, what about vibration plates? What about this? What about that? Blah, blah, blah. What do you absolutely recommend not doing? Is there anything that you can give as a blanket statement?
I would say I completely recommend against eating inflammatory foods. Like high sugar is just, it generates inflammation. And foods, I think a lot of women with lipedema have allergies. And if you have an allergy to food, you shouldn't be eating that food.
Lipedema in the arms. What do patients with large lipedema in their arms do, especially when most vascular doctors don't treat the arms? What's the next step for this patient population? Thank you, Natasha Wall, for that question.
So I think you can, your manual lymphatic drainage therapist can help you, your PTOT, LMT, who treats deeper into the tissue can help you, a compression garment could help you, like a shrug. You can, pumps are available for the arms. It's not, you can put your legs up the wall, but not a lot of people sit around like this. That's a little bit harder. So to elevate your arms. So I would say compression garments are your friend, pumps are your friend, and manual therapy. And if you get to that point, then lipedema reduction surgery.
Any relationship between premature ovarian failure and lipedema?
I think what I've noticed is that anytime you change hormones in the body, you can change lipedema. So if you have hyperthyroidism or hypothyroidism, that can change lipedema tissue. If you enter menopause, that can change it. If you enter puberty, it can change it. So anytime you change your metabolism, you can definitely change your lipedema tissue. Sorry, did I answer that?
Yeah, well, I think we're doing the very best we can. And yet the more questions we answer, the more are coming in. And it is really a sign of how much there is hunger to learn, hunger for answers. And unfortunately, they are not easily gotten. You are preeminent in this field. Everybody wants to know what Dr. Herbst thinks about everything. So that is a lot, and it's a credit to you. But at the same time, everyone, I don't know that we can get to every question. What I promise you we will do is we will download the chat and the Q&A, and however we can answer the remaining questions,
we will.
We get to it. We promise. We hope that you understand that we are now at an hour and a half, and we could go for yet another hour and a half with all of the questions. Dr. Herbst, so again, everybody, thank you. We hope you understand. Dr. Herbst, do you have any closing statement that you would like to make to the audience?
Sure. I think it's important to continue to push the envelope and try and figure out what causes lipedema. I hope that you got some great ideas today, and I hope that any of the healthcare providers in the audience take the baton and use your expertise and run with it, especially the vein specialists. And And I hope that within the, before I retire, I would love to really know how to treat, what causes lipedema and how to treat it and how to prevent it in our daughters.
How to prevent it in our daughters. That is a powerful way to end our presentation today. Thank you for your time, Dr. Herbst. Thank you to everyone who showed up. I'm going to put my email in chat here. For anybody that we failed to answer your question, I promise to try and forward it and get answers for you. Bottom line is we care. Lympha Press cares about your well-being, your improvement, and helping support you in your lipedema journey, which may or may not include Lympha Press. That's why everybody is invited to our monthly lipedema patient roundtables held on the third Wednesday of every month at 8 p.m. There is such a loving, supportive community there that has grown it. We've been doing it for 3 years now, and we hope that you will join us. We hope, medical professionals, that you will invite your patients to join in. And on the first Monday of every month, Dr. Herbst is available. She's having office hours for clinicians only. Our research roundtable is on the first Monday of every month. If you'd like to find out more, reach out to me. We will give you a personal invitation to that. Having said all that, wow, Lipedema Awareness Month is really every month at Lympha Press. And again, we're honored to have you on our team, Dr. Herbst. We hope you all have a wonderful late afternoon and evening, wherever you're logging in from. Take care, everybody, and thank you. Thank you, Dr. Herbst.
Good night. Good night. Thank you, Brenda.